That said, first things first, for those of you guys who have never been to one of our sessions, welcome to, I think, the 4th and 5th Con Ed section we've done so far. My name's James Weber, and most of you guys know me as the person who either taught your class or worked side by side with you when you taught a class, right? First, I want to apologize tonight. I have some version of Ebola, SARS, something, I don't know. I'm running a little bit of a fever. I got the sinus thing. I got the chest cold thing. I'm coughing up death, whatever. So just be a little bit understanding if you don't mind as we work our way through it. I appreciate it 100%, that understanding. Tonight's focus is actually going to be on Start Triage. Why are we focusing on Start Triage tonight? Because none of us do enough mass casualty type work, right? We do not see enough mass casualty in order to be proficient at it. And here's the thing, when it comes to the management of mass casualty events, it is so unbelievably vitally important that the first 5 to 7 minutes of your triage is accurate. And here's what we know from statistics. Statistically, we traditionally do a garbage job of effectively triaging people in that first of 5 to 7 minutes. Most conservative research suggests that we actually incorrectly triage patients about 70% of the time, right? Which is just ridiculous. And I kind of want to work my way through some of that Start Triage, how we would triage people, right? So what I'm going to start with tonight is actually a little bit of an exercise. So I want every single person who's watching tonight to grab a piece of paper and a pen, and do me a favor, pop up in the comment section when you got your piece of paper and your pen. We're actually going to do an exercise together. We're going to check ourselves once we're done. So, piece of paper and a pen, come on back. Put it in the comments when you're ready to go. I'll wait. Well, this is awkward. All right, what do we got? Put it in the comments when you got your piece of paper and your pen. By the way, in case anybody's unfamiliar, there's about a 4 to 5 second delay. That's the reason why I want you guys texting me with any questions or comments you have. That'll come through immediately. Ready? Good. All right. So here's what I want you to do. I want you to number from 1 till 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. I'm going to give you 10 scenarios of 10 patient presentations. And I want you to tell me, based off of the scenario that I give you, what color you would triage that patient. Red, yellow, green, black. I want that information right from you. And once we work our way through that, we're going to work our way through how to triage patients, and then we're going to go back to your sheet and see how close you got. Everybody ready? Awesome. Let me pull up my scenarios. All right. So, patient number 1 is a 30-year-old male that is ambulatory and complains of chest pain and dyspnea. "30-year-old male, alert, ambulatory, complains of chest pain and dyspnea." Patient number 2 is a 15-year-old female that is alert, is ambulatory, complains of left arm pain with an obvious open and angulated fracture. Patient number 3, a 17-year-old male, unconscious, snoring respirations at 4 breaths per minute with an open cranial injury with brain matter. Patient number 4, a 25-year-old female. She's alert, she's complaining of left leg pain, possible tib-fib fracture, and she is non-ambulatory. Patient number 5, a 62-year-old male, confused, complains of right leg pain and pelvic pain, and does not have a radial pulse, absent radial pulse. Patient number 6, a 12-year-old female, unconscious, closed head injury, apneic with an open airway with a heart rate of 40. Patient number 7, 70-year-old male, non-ambulatory, complains of right chest injury, respirations are 32, right? Again, respirations are 32. Moving to number 8, 25-year-old female, ambulatory, complains of a chest injury, a huge lac to the forehead with active bleeding. She's carrying an infant, and she's just hysterical. Just hysterical. Patient number 9 is the infant in which patient number 8 was carrying. Patient number 9 is apneic, right? Not breathing, but does have a brachial pulse, right? Unresponsive, apneic, does have a brachial pulse. Patient number 10 is a 45-year-old male, alert, non-ambulatory, complains of chest pain, respirations 30, radial pulse 140. I fully anticipate I'm going to have to repeat one of those. Go ahead, put it up. Adam, I'm going to re-record this later and make sure I'm going to do a screen capture of this later because we take these and we put them right onto D2L for our EMT students. I promise you, though, I'm going to take this and we're going to make sure that you at least have access to it in the next 72 hours so you get credit. Anybody have any questions about the first 10? Nothing at all? All right. So let's talk a little bit about this. Stand by so I put something in the live feed. Hold that thought. Oh, God. There's an interesting delay when I'm actually getting a delay when I bring it up on myself. That's fine. So we're going to put up a link here shortly on the start triage sequence, but we want to work through that together so that we're really clear on this idea of how we have to triage these patients. And again, we're going to go backwards to start to work through that content and make sure that those patients we just triaged together, we triaged effectively, right? We triaged effectively. 1 and 8. 1, 8, and 10, stand by. Got it, guys. All right, 10. 45-year-old male, alert, non-ambulatory, complains of chest pain, respirations of 30, radial pulse of 140. For you, Andy, 25-year-old female, ambulatory, complaining of chest injury, large lac to the forehead with active bleeding, carrying an infant, and she's hysterical. And number 1 was a 30-year-old male, alert, ambulatory, complaining of chest pain and dyspnea. All right, we're moving on to the next step. So let's talk a little bit about this sequence, right? So the start triage sequence is important to understand because it doesn't work like a traditional assessment. So much of our assessments that we do, right? Seat Safe BSI, working through primary assessments, we make our decisions based off of the resources the patients need. Start triage doesn't work the same way. The focus of the start triage sequence is legitimately focused on finding patients most at risk for death due to hypovolemic shock and shock in general, and getting them to resources first. It's almost entirely focused on that. And I'm going to explain why that is in a second. So when we come across an event, and I've been fortunate to manage a number of mass casualty events over the years. I actually managed 7 or 8 events back in 2007, 2008. I had a weird 2 years there. And those events taught me a lot, right? And what it teaches you is mass casualty management can become a really overwhelming thing. And when we have to manage a mass casualty, it's vital that we understand that the first several minutes of decisions that we make are hugely important. So start triage really is designed to make those first couple of kind of sequenced decisions easy, right? So let's talk a little bit about those first couple of decisions. When you're presented with a large number of patients, for example, back in 2008 in Abington Township, just outside of Philadelphia, I worked a large train crash, right? And we pulled up on scene, looked over, and there was this huge crowd of people kind of coming towards us like, ah! We had to treat and kind of figure out what we were going to do with that, right? So start triage works under the principle that you start where you stand and you treat the people directly in front of you, okay? And you treat you triage the person closest to you, right? And it's vital that you look at it through the lens of, I'm not looking for certain types of people. I'm looking to triage quickly, right? This is a quick process. The closest person to me. So how do we identify those folks? First thing, whenever you come across a large-scale event like that, look for a guy like me with a big, stupid, loud voice. Why? Because I'm the guy that can stand up and look at the entire crowd and go, everybody pay attention! If anybody can stand up, I want you to stand up, go over there. Because the moment any of those folks actually stand up and go over there, what happened? We identified our greens. Because anybody who's ambulatory is a green patient by definition. Understood? So anybody who has the ability to walk. Now, this is counterintuitive, right? Because let's suggest Janet is 56 and has 77 heart attacks, and she's got a god-awful cardiac history, and she's got chest pains, but she can walk. What color is she? Because on an ambulance, normal ambulance call, she would be ALS, and we call resources, and oh, this is terrible. But in the case of a mass casualty, if Janet can get up and go that way, she's a green. Because our green patients are identified first. That's our first order of business when we arrive on scene, besides scene safe, blah, blah, blah. Our first order of business, we've got to identify our greens. Our greens, stand up, everybody go that way. Once we work our way through our greens, and we get them off into a different place, we'll get back to them. Rest of this is simply just figuring out who the red and who the yellows are. I'm curious, do you think we're going to have more red or more yellow? More red or more yellow? Which one do you think is the most common that we tag people for? More red or more yellow? Give me something in the comments and the answer while I continue to talk. In the meantime, let's talk a little bit about the sequence, right? So, what's the first sequence decision in the start triage process? What's the first thing we're looking for? Well, we have to look at start triage from this sequence, right? RPM. Now, RPM is the three things we really focus on when it comes to start triage, right? So let's start with the first. The first, respirations. Does the patient have respirations? Comments, yellows and reds, red, good. It's actually remarkably more common. Okay, that's actually a really good assertion, because that's actually right. We tag a lot yellow, and we do tend to see progression into the reds as time goes on. That's good. So, first, respirations. What's the second? Pulse. Third one, mental status. Good. So let's talk about why these three things. Because it's not, do they have a high pulse or a low pulse? It's, do you have a pulse or not have a pulse? And where are the respirations by comparison in the sequence, right? I'm going to draw the whole sequence out here in a second. But first, respirations. Why do respirations matter? Why do we have to worry about respirations? Because respirations are one of the first indications that a patient is beginning to experience shock. Because when your body, because by definition, what is shock? Shock is hypoxia, right? So we've lost the red blood cells that carry the oxygen because I got wounds with lots of bleeding, right? So what's the end result? The body is like, holy crap, I need more oxygen. So what it's going to do? What's it going to do? Its first compensation mechanism is always going to be to increase what? Breathing, right? It's always going to increase respirations. So one of the first things we're looking for in the sequence, and we'll call this the making contact sequence. So our first contact is respirations. Now, when we look at our respirations, what are we looking for? We're looking to see how many respirations. And the difference is always going to be 30. Jesus. Sorry, guys. The difference is always going to be 30. 30 and above, or above 30 and below 30, right? Anybody with respirations above 30, that's an indication that we're starting to lean in the direction of shock. And as soon as that happens, that's a person that we tag red. That's a red patient immediately, right? That's a red patient immediately. Now, we've got, yes, Ebola. Definitely, I got Ebola. You got it. When we're still below 30 respirations, we've got to look to see what kind of the next step is in the sequence, right? Because that's a person who we're still kind of questioning, could it be something else, right? So at that point, we're going to start to look at perfusion, right? Do they have a pulse, right? Why does the pulse matter? Because the pulse really gives you the indication of are they actually moving some of that oxygenated blood around, right? So do they have a pulse? Oh, gotta go with the black marker, sorry. Also, do they have a normal cap refill? So really, when I spoke of P being pulse, is it more than that? I think it is, because P really also indicates perfusion. Because when we talk about pulses tell us something, but it really doesn't tell us the whole story. Assessing a patient's perfusion is really the important next step. How do we assess perfusion? Perfusion assessment is pulse. Do they have a pulse? What's the next step? Things like capillary refill, right? Why would capillary refill matter? Because capillary refill lets us know that we're actually getting some semblance of oxygenation in the periphery, right? So the oxygen's getting to the places it needs to go. So any patient with an indication of no pulse, bradycardia, or any patient who has longer than 2-second cap refill, that's an indication of poor perfusion. Conversely, any patient with a normal pulse, normal heart rate, that's an indication that it won't be, right? Also, skin condition. What does skin condition tell us in this circumstance? This is a good pickup, D. What does skin tell us in this circumstance? Skin condition tells us that in this environment, right, anybody who's blue probably is having issues with perfusion, right? Skin condition also tells us that patients who are pale, cool, and clammy are also patients who are leading in the direction of having poor perfusion, right? Good. Now, those are all indications of patients who are having challenges with perfusion. And going back to the original identification, why are we in a position of... Good. So why are we in a position where we're having challenges with perfusion? Like, why are we in a position where we're assessing for these things, right? When we're in a position where we're assessing these things, that's an indication of poor perfusion. So bradycardia, cyanosis, pale, cool, clammy skin. Now, can tachycardia also be an indication of poor perfusion with compensation? Yes. However, more often than not, when we're to the point where we're experiencing tachycardia, they're also having an elevated respiratory rate. At that point in the sequence, we tend to focus on patients who are no longer compensating, which is part of what keys us into the fact that it's a red triage, right? So these are patients that we triage red. Now, third part, mental status. Everybody remember the M? Mental status is one of the indicators of whether a patient is actually perfusing, right? And that's part of the reason why often in EMT programs, we teach additional oxygen for patients who are having challenges with altered mental status, right? Because we know that often hypoxia is a key leader in the direction of poor perfusion, or hypoxia is a key leader in the direction of telling us or showing us that the patient's hypoxic with an altered mental status, right? So that altered mental status tells us that they are hypoxic. So altered mental status is an important part of the sequence as well. So if the person's got no issues with perfusion, right? We then go to the next part of the sequence. And the next part of the sequence is going to be mental status. Good work. So mental status. What's the third part? How do we assess mental status? Right? How do we assess mental status? Pay up. Talk to them. Who are you? What's your name? What's going on? What happened? Do you remember what happened? Right? What's your address? What's your phone number? Count to 10, count backwards. There's plenty of ways to assess mental status. All of you guys, I'm sure, are in basic questions. Ability to follow commands. Good. And all of these are things that tell us, are they actually getting the appropriate amount of oxygen? Because remember, START Triage identifies patients most at risk for the shock that kills people during large-scale events. Right? So when do we do that assessment? Patients who are alert and oriented, right? They get tagged yellow. By the way, yellow markers work terribly on a whiteboard, so orange is yellow for today. Whatever. Patients who are altered, red. So again, above 30, below 30, normal, none. Do you think we tag a lot more yellow than red? The answer is there's a lot of patients that actually get tagged yellow and progress to red, right? More often than not. But this creates an interesting environment where when you look at the sequence of triage and you're starting to work your way through this, right? And you're talking to your patient, you're doing those assessments, it may very well be that a person who is really sick doesn't necessarily end up as a red or a yellow. That's okay, because the focus of START Triage is very different than the focus of assessments that we traditionally do in the field, right? Because assessments that we traditionally do in the field focus on identifying all problems uniformly. Triage, especially START Triage, focuses on hypoxia, shock, identifying those, getting them soonest to the hospital. I know I've hit on that point a couple of times, but it's actually pretty practically important to explaining why that this is so different, right? Now, you think that's going to be hard to remember when you get in the field? Yeah, it's going to be hard to remember when you get in the field. So anybody who goes to tonight's training, I'm actually going to have a 3x5 card that I'm going to send to you guys via email. When I send it to you via email, you have the ability to cut it out, throw in your wallet. You got a reference card to go, James gave me this. Woo! All right, let's triage people. Bing, 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 bing. It's also going to be found on the START Triage kits. Now, the reason why I include this is not every organization is actually using START Triage. It's important that you understand what sequence or what tools you have, whether it's traditional triage tags or START Triage tags, whatever. But this sequence is the one that tends to save the most lives, right? Good. So let us go back through our 10 patients. Let us go back through those original 10 that we worked through. So everybody pull out that piece of paper, and we're going to go through it together. Let me ditch these markers. All right. In the meantime, while I got a quick moment, I'm pulling this up. We got some holes for the advanced EMT class coming up in the spring over at the college. So those of you guys who are EMTs, not yet advanced EMTs, come out and see us, right? Kevin's going to do some good work. Kelly Miller's going to do some good work. We got a big, awesome team just waiting to take care of you guys. I know a couple of you guys got applications in. Make sure you get them in real soon. The cutoff is January the 12th. When's the cutoff? January the 12th. So make sure you're there and well taken care of. Now, all right, so let's go back through the sequence again. We're going to work through them one by one. Everybody got your stuff up? Good. Patient number one. Let's remind you of patient number one. Patient number one you come across is a 30-year-old male that is alert and ambulatory, complaining of chest pain and dyspnea. Now, Anytime you come across a patient with chest pain and dyspnea and he has a history, man, oh man, when you think about that, that's a sick patient. Chest pain, he's got a dyspnea. He's 30. I'm older than 30. If I have chest pain and dyspnea, that's bad. But is that a person we call for? Is that a person we would tag red? If you tag that patient red, 30-year-old male, alert, ambulatory chest pain and dyspnea, you'd be wrong. You would. If you tag that patient yellow, you would also be wrong. Any patient that is ambulatory, regardless of the complaint, gets tagged as green. So again, patient number 1 is green. Patient number 2. Patient number 2, 15-year-old female, alert, ambulatory, complains of left arm pain, obviously open, angulated fracture. How do we tag that patient? Patient number 2 tags as green as well, right? Open angulated fractures, big nasty stuff, still tags as green because she is ambulatory. Patient number 3 is 17-year-old male, unconscious, snoring respirations, open cranial injury with brain matter. 17-year-old male, right? Assessment, respirations, they're below 30. So, is he perfusing? Not with snoring respirations, he's not. If he's not perfusing, he gets tagged as red. Now, let's talk about this. Patient number 3, 17-year-old male, unconscious, snoring respirations, open cranial injury with brain matter. I think there's a reasonable argument to be made that that person can be tagged as black. Why? Is open cranial injury with exposed brain matter a survivable injury, yes or no? Is open cranial injury with brain matter a survivable injury? Yeah, we're getting the right stuff. That's a patient that I think is a reasonable argument to tag black. Now, that said, technically, according to the sequence, if you go strictly off of RPM, that patient, right, that patient would actually get tagged as red. But injuries incompatible with life, perfectly okay to make that patient correct. Frank, it's like Frank and I are like right on point. It's injury incompatible with life, perfectly acceptable to tag that person as black. Number 4, 25-year-old female, alert, complaining of left leg pain, possible tib fib fracture, not ambulatory. How do we tag that person? Well, assessment. She's non-ambulatory, so she's immediately not a green. Doesn't say anything about a respiratory rate, right? Left leg pain, she's altered. She's nothing about not being altered, nothing about acting inappropriately. It just says simply, she's got a fracture and she's alert. That person's actually going to tag as yellow. 100% agree. 25-year-old female, alert, left leg pain, possible fracture, non-ambulatory. If you were in registry to be given this scenario, that's 100% going to get tagged as yellow. It's good work. Patient number 5, 62-year-old male, confused, complains of right leg and pelvic pain with absent radial pulse. Well, this one's going to be real easy, right? It says nothing about his respirations, but that doesn't matter. He's absent a radial pulse while also being altered. Indications of shock, hypoxia. This is a person we need to get to a surgeon. That's going to be at the top of the list. We tag him as red. Good work. Guys, give me 2 seconds. I got to get a drink. I'm dying on the inside here. Hold on. All right, thanks for the understanding. Sorry, I love you. All right, so let's go to number 6, right? So patient number 6, 12-year-old female, unconscious, closed head injury, apneic with an open airway, heart rate of 40. Ebola is killing me. 12-year-old female, unconscious, closed head injury, apneic with an open airway, heart rate of 40. So here's what's interesting. Yeah, no joke. So here's what's interesting, right? When you come across a person who is not breathing, this is something we haven't talked about yet, right? When you come across somebody who's like 8 to 10 years or older, when you come across those folks, whiskey does kill germs. Unbelievably true. When you come across those folks, guys, let us be reminded of the fact that we open the airway and we make one attempt to open the airway. If the patient still isn't breathing, they are tagged black. Let me say that again. That 12-year-old patient who is not breathing, and it says not breathing, and we attempted to open the airway. Anytime you come across a patient from that's in the 8 to 10-year-old range and higher, right? These are patients where we attempted to open the airway. When we open the airway, if they don't start to breathe on their own, they do get tagged as black. We run into some circumstance with this where, especially in this particular case, because she's 12, everybody goes, she's 12, we've got to try. Here's the thing, guys. Medicine puts us in a position where we have to give as many people the best chance that we can. And the answer to giving as many people the best chance that we can is 100% making sure that we're not wasting our efforts on one person while everybody else dies. So even though she's 12, doesn't matter. We've attempted to open the airway, head tilt, chin lift, or, jaw thrust, whatever. It didn't work, so we move on. 100% our obligation. We then move on. Good work. What's next? Sorry, passcode. Ugh. All right, number 7. 70-year-old male, non-ambulatory, right chest injury, respiratory rate 32. 70-year-old male, non-ambulatory, complaining of a right chest injury, a respiratory rate of 32. Only thing that matters. True respiratory rate of 32, he will always tag as red, even though it could be just a cut on his chest. When I say right chest injury, I mean, that could be just a small laceration where he's like, I'm fine, I'm just breathing a lot. Doesn't matter, because this particular patient, respiratory rates above 30, falls in the RPM sequence to be tagged as red. That's real good work, guys. Let's go to the next one. 25-year-old female, ambulatory, complains of a chest injury, lack to the forehead that's bleeding, carrying an infant, and is hysterical. This one's going to be interesting, right? How do we tag this patient? She's ambulatory. How does she tag? She tags as green, right? These are the patients when you have an ambulatory patient and you look at them and say, everybody get up and go that way. We tag her as green, right? Because she's ambulatory. But this gets a little weird for a second. Patient number 8 is a 25-year-old female, ambulatory chest injury, laceration of the forehead, carrying an infant, hysterical. Here's the converse part of the argument. She's carrying her child, an infant, who is apneic with a present heart rate. How do we tag patient 8, and how do we tag patient number 9 because of patient number 8? By the way, I said nothing about opening the airway, staying apneic. She just isn't breathing. All right, Torre is 1 for red, number 8 for red, number 9 for red. This is where we're forced to make some judgment calls, right? RPM isn't a position, 8 yellow, 9 red, okay? Red for both. We got some yellow, maybe mental status. Good, okay, I like it. So this is an area where it gets a little fuzzy, because if you tag mom, green, go over there, mom, and I got the baby who probably tags as red, you now have somebody who's got to manage a baby. It probably makes more sense operationally for you to take mom and kid with one red tag and push them off. Hey, go, mom, just carry the kid, you're good. This, I think, puts you in a position where you're going to be the most successful. So again, reason why I bring that scenario up is it's not perfect. It isn't perfect, right? RPM requires you still to sometimes make a judgment call. But ideally, 99% of the decisions you're going to make are set up for you if you follow the sequence. This just isn't one of them. Me, I would tag both mom and child as red, set them off. There are other people who would do it differently and wouldn't technically be wrong. This is the area where we go from, medicine's kind of an art form. Triage is kind of an art form, right? And that's okay, right? That's okay. So just understand the fact that it's a good way to do triage, but there are scenarios where we've got to make pointed decisions. Let's go to patient 10, a 45-year-old male, alert, non-ambulatory, complaining of chest pain, respirations of 30, and a radial pulse of 140. I love this one, right? Look at the sequence. Again, 45-year-old male, alert, non-ambulatory, complains of chest pain, respirations of 30, and a radial pulse of 140. How do you tag it? Post it up. Good. Red. Good. So here's what's interesting, right? It says below 30 and above 30. The original inception of when they wrote Start Triage did nothing for the patient with a respiratory rate of exactly 30. It dealt with the ones above 30, dealt with the ones below 30. The folks at 30 are like, meh, yeah, good luck to you. So guided documentation for how to do Start Triage has been updated the past couple of years to say 30 and above, red, 29 and below. The reason why you still see it is it's just not as cool to write 29 and below and 30 above. So basically say above and below 30. But 30 on the nose, that gets tagged as red. That's a good way to do it, right? Yeah, and that's going to be part of that sequencing that occurs. All right, so I want you to post, I want you a little bit of self-awareness here. When we started tonight's lab, right? I told you that 70% of initial triage is wrong. It's wrong. And I want to do a bit of a sequence. I want you to be honest though, right? I want you to compare when you did the sequence initially, when I gave you those first scenarios at the beginning of tonight's discussion, and the second time I gave it to you after and drew out the chart, you can look at the chart. What percentage did you get right the first time? There's 10 questions, so 50%, 40%, 30%, 70%, 90%. Post it. By the way, the average is actually 30%. People get this 30% correct the first time and 90% correct the second time. I want to see how you guys did. Do me a favor. Post it in the comments for me, please. I got to clear this board off. Be honest, by the way. About 80% right, 70% right, 50% right, 40% right, 70% right. Good. Now you see why, when all of you were in class, I looked at you and said, anytime you have a chance to review Start Triage, do it. Because no joke, when it comes to true scenarios where you actually have to do these kinds of assessments, You must get it right. The more times you review Start Triage, when you are put off in front of the actual scenarios, you're going to come closer to getting it right. Because getting Start Triage right in the initial part, right? Earlier you get it right, the better off you're going to be, right? Awesome. Nice work. Guys, we got through this about 18 minutes faster than I was anticipating. So here's the deal. I want to give you guys a 5-minute rundown of the incident command sequence for a mass casualty event. Everybody okay with burning up the last 18 minutes working on mass casualty incident command type stuff? Yes or no in the comments. And I'm going to get a drink because I'm dying on the inside. Go. Two thumbs up. Yep. Awesome. Good. Then we're going to move on. Sometimes when I decide to whiteboard instead of PowerPoint, what ends up happening is I talk faster than PowerPoints. This is the reason why I hate PowerPoints, by the way. It's the reason why you never see PowerPoints in any of our programs is because it's easier to explain stuff when we can actually just work through it this way. So let's work through the first 5 minutes, and here's why. I'm going to guess that most of you guys have never been the incident commander for a mass casualty, right? You've probably never been in a position where you have been the person in charge of a large-scale mass casualty event, right? Would you agree with that? Here's the thing. For a duration of event, you will probably not be the person in charge of the entirety of a mass casualty when you come across one. And that's okay, because often, right? Oh, okay. Jake Wentz is totally going to be teaching this class next time. Brother Wentz, yeah, you're writing me a story later in an email, my man. Here's the thing. When it comes to running these kinds of events, right, the most important thing you could do is put the right people in place in the first 5 to 10 minutes, right? Because honestly, if you do the tasks in which you have to do in the first 5 to 7 minutes, it is a game changer, right? Ooh, Deidre asked an interesting question. For mass casualty events, any thoughts on eliminating green tags altogether? They could walk away or go to an assigned area. Deidre, actually, here's what's funny. That train crash I told you about, I took all the green tags. I pushed them actually like past an alley into an open spot. They were 4 blocks from a trauma center. The train crash actually happened 4 blocks from a trauma center. You know what I did? I looked at them and said, the hospital's 4 blocks that way. Go. And they went, okay, and they left. Guess how they got to the hospital? Foot, no longer my problem. 4 blocks. I'm okay with that. When it comes to running a mass casualty, we have to be in a position where we're a little bit creative with those green tags. I don't know that I've ever actually green tagged people before when you have them separated and working in a different area. It's a great idea. Anyway, let's get into those first couple of sequences, right? Because I tell you, when we talk about somebody having to take on an incident command role or a person who might be in charge, it scares the crap out of people, right? Because especially if you've never had that situation, just know that a lot of people are fearful of, oh my God, maybe I'll sound dumb, maybe this won't go well. Here's the deal. As somebody who's listened to mass casualty events, been a part of mass casualty events, and been the incident commander for mass casualty events, you should know that everybody who runs a mass casualty event sounds stupid. They do. And it's because we don't run enough of them, right? So whether it's you're the person who sounds dumb or somebody else is the person that sounds dumb, we have to do the work correctly as best we can, and that's okay. And I want you to know that. So first things me and trades, yeah, right? How about it? So when we talk about an event like this, our first step has to be switching to a black marker. All right, so our first step has to be to identify that we have to take on a lead EMS command or EMS, branch division leader type person. We're the person who is in charge of EMS operations, okay? And that's going to traditionally fall underneath an incident commander. So that person, we'll tag them as an incident commander for now. But more often than not, our EMS people really fall in a role where we oversee the EMS portion. Absolutely, 100%, right? Me too, Becca. Here's the thing. That's where we're in charge of that EMS portion, right? So there's a couple of tasks that actually have to occur, right? First, triage. Second, treatment. Third, transport. Good. So incident commander has an obligation to basically establish a management chart. It's funny, I own a couple of businesses, and here's how I normally compare this. When you're an incident commander, it's the reverse of running a business. When you run a business, you build a management team, and then you build a product below it, right? Conversely, when you have an incident that you now need to take control over, you have the product, you just need to build the management team to actually get control over what's happening, right? So that's the true definition of incident management. And when you arrive on scene, your obligation as the EMS provider is to start to develop your management team who's going to help you manage this event to success, right? So you are the incident commander, unless you decide not to be. Now, who could be an incident commander? I've had circumstances where I pulled up and went, my partner's run like 40 of these. He's going to be the incident commander. Conversely, I've had circumstances where my partner looks at me and goes, you've run like 6 or 7 of these. You're going to be the incident commander. Work within the talents of the people you have. That's okay. There's nothing wrong with that, right? But everybody in that first ambulance is going to have to assume some semblance of a position, right? You're going to have that person who's in charge of the EMS work. You're going to have that person who is in charge of triage. In your first 5 to 7 minutes, you can assign a treatment person, you can assign a transport person, whatever, but until the patients are triaged, there's no other tasks or obligations. What do I mean by that? You can decide, hey, listen, you're the transport person, you got to figure out where all these people are going, but until you know how many patients you have, of what varying degrees of brokenness, are they red, are they yellow, are they green, until you know that, until you have a patient count, literally nothing else matters. So until you, when you arrive, you establish yourself as a person in charge, you establish your triage person, everybody else that shows up triages until you run out of people to triage. Okay? That's your obligation. Get all these people into established treatment section. What do I mean by an established treatment section? Some place where you're going to pull sick people to treat them and continue to triage them to evaluate and assess their ability, them for any changes in condition, right? Because if there's enough hazards to injure them, maybe it's a crash on 78, maybe it's a big giant house fire, we need to get them away from whatever the hazard is to be able to treat them in a place that's safe, right? So once you get them into that treatment area, at that point, we can begin to just simply treat patients, right? And then, of course, we need to make the arrangements to start to move people around for transport. And that's the task of the transport officer. I want to talk a little bit about what each person's actual individual task is, right? Because I think it's important to understand what your role is should somebody walk up and go, you're the triage officer, you're the treatment officer. I've told this story in EMT programs in the past. There was a mass casualty event of a nursing home that caught on fire. We had to transport more than 500 people out of Allentown about 20 years ago. And I tell you, I was 18 years old in Dorney Park, because we actually treated these patients in Dorney Park, bagging 2 people, wondering how I got myself into that circumstance. I got myself into that circumstance because I was dispatched to and put within the confines of the treatment sector. I was the person who was tasked with treating people in the treatment area until we found an ambulance to transport them, okay? So we're going to work our way through that next. So triage person. We do the initial triage. They oversee the triage function. Then what? Their next focus is to continuously triage. So let's suggest there's 80 patients. We triage them all, and we move them into the treatment section, and the treatment people are treating. What do the triage people do? Go home? No. I finished my triage. What am I going to continue to do as the triage person? Triage. Your entire obligation is to continuously triage. Why? Our triage is wrong 70% of the time on our initial triage. It is. It happens. So how do we solve that our triage is wrong initially for the first 70% of triages? We continuously re-triage on a loop. So you triage your patient, you decide what the color is, you move them to the treatment area, and then the triage people continue to triage until we run out of patients. That's all you gotta do. Triage, 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 triage. That's it. What do our treatment people do? Treatment people treat. But are we treating completely? What's our focus in the treatment area? Our focus in the treatment area is life-sustaining treatments, right? What do we mean by life-sustaining treatments? If Janet needs oxygen or she's going to stop breathing, we'll try to get Janet some oxygen. If Jane is bleeding from the arm to the point where it's craziness, we should probably get Jane a tourniquet, right? Maybe John is having, whatever it is. As long as it's not CPR, because we need a lot of people for CPR, life-sustaining, life-saving care occurs in the treatment area, okay? It just does. Now, does that vary sometimes? Sure. I had a case of the CO that filled a mall, actually the food court of a mall, had 137 patients, all vomiting all over the place inside this mall. And I tell you, it was disaster on the inside of this mall, right? Everybody did this right thing. They walked outside, and all of a sudden they felt better, but they wanted to go to the hospital. Mass casualty event, 3 to 4 to 5 greens going at a time until they were able to get our hands on a bus, right? When all of your patients are green, we're less concerned with life-saving treatment. These are folks in which we were able to do some more comfort care. But more often than not, for a mass casualty event, we've got to focus on life-saving, life-sustaining care. Exactly, focusing on those ABCs, good. Transport officer, I've long said the transport officer is the worst job to have in this kind of an event, right? Transport officer is the kind of job where you are constantly working. Why? Because you got to figure out where these people are going to go, right? And that's a hard job. How do we figure out where these people are going to go? First, we got to figure out how many people we have, because from a resource perspective, that's important, right? And then we've got to do some coordinating with hospitals to try to figure out where we can put these people. Good example, that train crash with the trauma center 4 blocks away, the hospital called and said, hey, just give us all the traumas. I said, there's like 50. To be clear, you would like 50 traumas at the same time, because that seems like a dumb idea in a town with 3 trauma centers. Here's the thing. We have to efficiently manage where we send our trauma so that we don't overwhelm resources, because our patient's going to efficiently be treated if we overwhelm one hospital. Let me give you a good example of that, the Las Vegas shooting. If anybody wants to actually, maybe I can put it out in the comment notes after this. The review articles for what those folks did for treatment and trauma care because of the limited hospital capabilities in Las Vegas and the number of people who had been shot during that event, the large-scale shooting, 500. Las Vegas doesn't have the capability of treating 500 patients that are shot simultaneously. They just don't, right? So when it comes to the transport obligation, we don't want that kind of an event to occur unless there's no other option, which is basically what happened in Vegas. We need to be mindful of understanding the resources of the hospitals around us. So your treatment officer, ideally, is the one that says, okay, I have 75 patients. I should probably call the closest 7 or 8 hospitals. Now, who can make that phone call? More often than not, 911 dispatchers are pretty good with that, to say, hey, listen, I want you to reach out to the closest 7 hospitals, find out how many greens, yellows, and reds that they can take. Now, ideally, hospitals are supposed to actually know how, that is a typical food court, 100%. So hospitals, ideally, are supposed to understand the red, yellow, green, black concept for triage. They don't. They just don't, right? Actually, ask instructor Lenny Brown about this. There was a nursing home fire in Chester County where some of the hospitals around said, what? What colors? What patient? We take all the colors of the patients. It's fine. Hung up the phone, right? I got to tell you, that's not what he was asking, right? He was asking how many of specific types of patients, but the hospital wasn't clear on what he meant. When it comes to these kinds of an event, it's important that we understand that hospitals are supposed to be clear on our system, but aren't always. And we need to be understanding of that where we can, right? So just be patient in that circumstance. And then what's the focus? Literally, you just send all the red patients to the closest hospitals that can accept red patients, then the yellow patients, then the green patients, either in a school bus or whatever, and we get them off to a hospital at some point.